Today we are supposed to read all the instruments, but whatever instruments is available with us, we'll do those things today, and rest of the instruments probably we'll do in the next class. Okay. So coming to instruments, I'll like you all to volunteer. I think everyone is probably aware of the basic instruments. তোমরা পড়েছো? কেউ আগে কখনো ইনস্ট্রুমেন্ট নিয়ে পড়েছো কিছু? No, I have not read. You can tell clearly, no? Not a problem. The students. Alright. The first instrument we're going to start with the most common instrument we use in a day-to-day ENT practice. It's a full name. Jobson Horne. So there are two sides. Now you tell me. This is Jobson Horne Probe. There is a Jobson Horne Probe with a Ring Curate. It is important. So when you are given an instrument in the examination, it's very important that you complete the full name of the instrument, including the name of the scientist or the person who has discovered it if required. It's not for like a Jobson Horne Probe you are mentioning, right? So this is the probe part and this is the curate part. So what is the use of this instrument? Okay, then yes. Then curate will do curettage, right? So that's very obvious now. So tell me, so if you see this one side is serrated, okay, it has serrations, fine serrations. So what is the purpose of this serration? So that we can wind the cotton and it stays in place. This is a typical way of winding this cotton. Okay. What? So the flared end, so the one which is open, that will be distal. So that will be outside. And we will put it and rotate it only one direction, not like aeromenum. We'll rotate it only one direction. Okay. And this side will be open like this, so that it doesn't cause trauma. So if we do it like this becomes firm again and that can cause trauma. So the idea is it should be like this. Okay. So once we put this in the ear, for example, we are doing oral toileting, cleaning of the ear or whatever, and we are putting this in the ear. We always do it on direct vision, right? We use a headlamp or a headlight or maybe a Booth lamp or whatever. Under direct vision, we are visualizing, we are doing oral toileting, and we tend or try to move this in the same direction always. We don't wipe it like this. We move it in the same direction. Why? If this gets adhered to somewhere and we are moving it like this will come out and the cotton will stay inside. But if you move it in the same direction, it will never come out. It will always come out with the instrument. So this is very important that we move in the same direction. So this end is primarily used to attach a cotton for oral toileting, ear cleaning, mostly for discharge. There may be a discharge, there may be bleeds, there will be fungal, like onomatosis, there may be fungal debris that we need to clean. And the other end is a curate. This is for firmer or harder objects, like if there is a wax stuck in there, impacted wax, or maybe any other foreign body stuck in there, and you can visualize the foreign body, you can change. Using higher frequencies is what? Routinely we always use a 256 or 512, right? So previously it was 512. Scott Brown now says it's 256. Scott Brown in our ENT mother book, so it now says it's ideally 256 hertz, but then we still use 512 most of the times. Why don't we use a 1024? Damping. So it's very early damping. The sound stays for a very short while. The patient gets no time to appreciate the noise. Okay. So when we are doing a Rinne or a Weber or ABC, the patient has to understand the sound because they are not pro. See, you are the examiner, you are pro, you know how the sound is, you know everything, but the patient doesn't know anything. So it takes 1 or 2 trials for them to understand what the sound feels like, and then they can reciprocate when it stops, when it starts, and all those things. Okay, so সেটা তাহলে পরে আসছে, এই জন্য 102 আমরা commonly use করি না, and most of our normal speech, our normal day-to-day activity sounds, the range is 500 to 2000 hertz, 1500, 500 to 1500 hertz most commonly. Okay. So the ideal is using a 512 hertz for all practical purposes. Okay. Achha. Then comes, first is this one, is very important. What is this called? Full name, please. It's a lax tongue depressor. Okay. See, they will only ask you these things. They want to know that you have read or not. Okay, so it's a lax tongue depressor. What is it used for? So what will you tell the patient when you are using this? Open the mouth and then, this is the mistake. You never tell the patient to protrude the tongue. The tongue would be inside the mouth. Okay. So once you protrude the tongue, you cannot depress it. Okay, the tongue should be inside the mouth, and then we'll depress the tongue. So for examination of what? Pharynx, oropharynx. For example, oropharynx. Oropharynx includes the tonsils, posterior pharyngeal wall. Okay, so for examination of oropharynx, we use the, and what is, and then the examiner commonly asks what are the other uses. Sample. That is started. The area of both sides. Okay, so this is a cold, basically, because it's flat and it's metal, so it's mostly cold. So when we breathe out, because vapor on both sides, and we can examine from size of the the vapor formed, whether which side is more patent than the others. So this is just a gross test. Okay, this is not an important test anyways, and is also used for retracting tongue during surgeries at times. Okay, but these two are the most common uses. Okay, and we will come to this. So Thudichum, nasal speculum. Okay, what is it used for? What is the procedure we do with this? Anterior Rhinoscopy. Okay, and I taught them when the class was there how to hold this instrument is very important. So the examiner will give you the instrument and will tell you hold it properly. See, it's always a challenge, this one. It's the only instrument probably which is difficult to hold if you do not know. So your index and the thumb. Okay. So first is, see, this is the instrument, right? So it has two blades. The blade has to go inside patient nose, so it should be away from you. Okay, so the blades go towards the patient side first. This is like that. Then with the left hand, important, left hand, not the right hand, left hand, the thumb and the index fingers, you just let it hang like this. Okay, so you are hanging it from the index finger and holding it with the tongue, securing it with the thumb. Okay, a blade towards the patient, and the middle and the ring finger will come on either side of the speculum. Then you close it, insert, open. So once again, left hand, thumb and index fingers. You take the index finger first, let it hang, the blade towards the patient side. Fix it with the thumb. So now it is fixed. We have 3 more fingers. The little finger is of no use. These 2 fingers will come on either side. One on the left and one on the right side. And then you press it with these 2 fingers. So it's initially difficult to do. So once you get used to it, we do it. You don't have to do it. You just have to show it how it works. Even if you are unable to, actively do or examine, it's okay. You should know the procedure. Okay, this is how it goes. So then we insert it and open it. So once we release it, because the recoil, it opens up. It opens the nasal cavity. Okay, so this is the Thudichum nasal speculum used for anterior rhinoscopy for examination of what all the structures. What are the structures we see for with anterior rhinoscopy? In anterior rhinoscopy, key structure देखिए, vestibule of the nose, vestibule आगे, always say external nares, external anterior nares, okay? Anterior nares and the vestibule of the nose. Then we see the nasal mucosa first, the overall character of the nasal mucosa. Then the septum, the inferior turbinate, if possible the middle turbinate. Further is usually not visualized. Okay, so we see both sides separately. You see first the disease side and then the opposite side. If the patient has a specific complaint, if you are generally examined, you can see any side first. There is no convention that you have to see the right first or left first. But since we are right-handed people, most of the time when sitting in front, it's easier to start with the patient's left side and then see the right side. That's how we do it on a regular basis. Now, what is this? Laryngoscopy mirror না, আমি আবারই বলছি, একটু আগে বলেছি, laryngeal mirror. It is important because you cannot call it a direct laryngoscopy or indirect laryngoscopy mirror. No, there is a procedure. The name of the instrument is a laryngeal mirror for visualization of the larynx. Okay, what procedure we do with it? Indirect laryngoscopy. Direct is when you directly visualize. Indirect is because you are seeing with the mirror. It is একই জিনিস. It's the same instruments. So যেটা বলছি এটা PNS. It is something else. It is not for larynx. It's for posterior nasal space, for the nasopharynx. Okay. So this is a laryngeal mirror. Okay. So how do we use this? Fail. मतलब इस टेबल में तो फेल, पूरा तो पूरा पास हो जाएगा. See, the difference between these two is, this is a PNS mirror. I think you have an idea. It's carved, okay? Because we have to negotiate it to the posterior to the uvula. We have to go posterior to the uvula and see the nasopharynx. Okay, that's why this is used, right? So in that case, you will have to depress the tongue and go there. This is something else. This is a laryngeal mirror. So we need the larynx to come up, come anteriorly as much as possible. So we will tell the patient to open the mouth, take the tongue out. We will hold the tongue and we'll warm this mirror. In examination, always say warm. Don't say Savlon or any other thing. We warm the mirror in warm water and always. This is a trick. The exam. I don't know if undergraduate में ऐसा करता है कि नहीं, लेकिन पोस्ट ग्रेजुएशन तो खूब ही देखे जे तो ये टेम्परेचर चेक करतीस किना, because you will touch the patient's palate. So once you warm it up, ideally you should check the temperature. It is acceptable or not, whether it is too hot or not. You should not burn the patient's palate. Okay, so I'll check the temperature and then we'll hold the tongue. So there is a specific way of doing it. We don't have a gauge piece over here. So what we do is, we suppose the go around again. I won't do this thing on. Don't do it. Okay. So we have the headlight on, okay, or the bull lamp, whatever is. We have it fixed. Okay. We have the light in here. The light is focused in the patient's mouth. Okay. Open your tongue. Okay. Take your tongue out. Okay. So I have this mirror in my hand. Okay. So what I do is, with these two, we hold the tongue and with the other finger we raise the lip. So like this, এরম ভাবে আমি ধরেছি, এটা দিয়ে we push it up and we hold the tongue with these two fingers. Okay. So the tongue is out, then we put it, we rest it gently on the palate, at the base of the uvular region, the soft palate. Okay, and we try to visualize the larynx. It is not a very easy procedure. It takes a lot of practice to visualize the larynx. শুরুতে আমাদেরও কিছু দেখতে পারতাম না, কিন্তু করতে 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 হয়ে যায়। So you get used to seeing things. So what all things you can see with this? Kiki laryngeal mirror দিয়ে what structures do you see? আগেই vocal cord দেখবি, go gradually. Base of tongue first, vallicula, then epiglottis, laterally from নিচে উপরে at the level of epiglottis, lateral what do we have? Epiglottis is again posterior. Pharyngoepiglottic folds or PE folds. Okay, that is the posterior border of the vallicula. Right? The vallicula ends in the PE folds, and then we have the inlet of the larynx, piriform sinus on both sides, and then from the base of the epiglottis we have the two AE folds, adiepiglottic folds, that goes to the arytenoid. Okay, and the interarytenoid region we can see the false cords and the true vocal cords. We can see the piriform sinuses on both sides. Say one day we'll do a fiber optic laryngoscopy to show you the structures. It will be easier for you to understand how things look like. It's very difficult to explain, I mean, by just verbally about what all structures you see. But it's very interesting actually. Once you see it, once you visualize it, you will never forget. So once you try to gulp, you will forget. But once you see the structures, you will never forget. It's very clean and very interesting. So we go step by step. Whenever the examiner is asking you about what all structures you visualize, start with the superficial one, the outermost part, that is the base of tongue. Then go gradually. Base of tongue, vallicula, epiglottis, pharyngoepiglottis, epiglottic folds, then the adiepiglottic folds, the arytenoids, the interarytenoid region, okay, bilateral piriform sinus, the false cord, and the true vocal cords. Okay. Subglottis is usually not very well visualized by a laryngeal mirror. It is extremely difficult. Okay. Postcricoid area is also not properly visualized by a laryngeal mirror. We need a direct laryngoscopy for that. Okay. So here goes the laryngeal mirror. Okay. Then the next instrument is this. This is one of the least used instruments. We never use it. We never practically use it. I have probably used it maybe 10 times in my life, and I'm working as a ENT surgeon professionally for 11 years now, post MS. So maybe 10 times I've used it at most, not even that maybe. So what is the purpose? It is a PNS mirror for posterior rhinoscopy. So anterior rhinoscopy we do with the Thudichum speculum, and this is the mirror for posterior rhinoscopy. Here we depress the tongue and we tell the patient to breathe from bhav. Think about it. See what happens when we are breathing through the mouth and we are breathing through the nose. What is the difference? That is, I'm not asking of the physiology or the moistness or anything. So I'm just asking about what is the difference in the structure of the mouth. So what is the only mobile part in the entire mouth?
Soft palate.
The soft palate. Okay. So what is the role of the soft palate? If the passavans reach, it closes the nasopharynx from the oropharynx. It separates the nasopharynx from the oropharynx. Okay. What I am trying to see here is the nasopharynx. So it's high up. It's above the soft palate. So I want the soft palate to be open. So if the patient breathes through the nose, then only the soft palate will open up. I'll be able to see. You understand what I'm saying? I will never forget if you think about it this way. See, if the patient is breathing through the mouth, the soft palate will be closed. I will not be able to go behind it. So my idea is to go behind the soft palate. So I'll tell the patient to breathe through the nose. We'll warm it like the laryngeal mirror. Same. We'll see the temperature. We'll depress the tongue and then gently introduce this to go behind the uvula. See here, adenoid is present. Adenoid is not always present. If you are examining an adult, adenoid may not be present. Right? what are the structures that are always present? That we say Puana. First and the foremost is Puana. Lateral nasopharyngeal walls that includes the eustachian tube opening and the fossa of Rosenmuller. This is not very clearly visualized, to be honest. I have never seen fossa of Rosenmuller through this. Torus tuberous is the eustachian tube opening. So the swelling of the eustachian tube opening that you can visualize very clearly. Okay? So, and if there is a pathology in there like adenoids, or don't say the pathology first, always say the normal anatomy first. Okay? Then the examiner will ask you what are the diseases that you can find out over there. So it can be adenoids or it can be a nasopharyngeal tumor. Okay, these are the most common pathologies in the nasopharynx. Okay. There are multiple other pathologies like pathological eustachian tube, all those things, but you cannot see it with this mirror, so it doesn't work. Okay. What is this? Full name? Bullam tektoge. Tooth dissecting forceps. Dissecting or dissecting, whatever. Tooth dissecting forceps. It's not only a tooth forceps, it's a tooth dissecting forceps. Okay. So this actually, someone was telling me in that class that it's a tonsil holding forceps. Tonsil holding forceps is different. Okay, it's like a, have you seen sponge holding forceps? The tonsil holding forceps almost looks like that. Almost similar to that, except that it is, the plane is different. Okay. So we use this for, this is not specific for ENT. We use it for all the surgical procedures to hold the soft tissues, hold the skin most commonly. Okay. So this has the teeth in there, so that's why it's a tooth dissecting forceps, and it can be a non-tooth and it can be when it is plain. So we are holding soft tissues where we don't want trauma, we use the non-tooth dissecting forceps. Okay. So what is this? Full भी ब्लड प्रेशर हो तो बारे तो क्या है ब्लड प्रेशर भी हो सकता है ना तो क्या है it's called a Bard Parker handle. Okay, so BP handle, so there will be a blade also in there, so based on the size you will have to, so this is a number 4. So there are multiple sizes of the BP handle. Based on that, there are multiple. What all blades will fit into it depends, it varies. Okay, so there are multiple sizes of the blades. Most commonly used surgical blade is number 15. 11 is not for incision, it's for stabs. 11 is sharp. Okay, so they won't ask you all these things because they won't go into surgical details. They will never go into surgical details for undergrads. So Bard Parker handle. Okay, there are multiple sizes. Like I said, this one is number 4. So if they give you this instrument, try to read the number and say this is number 4 Bard Parker handle without the blade. Or you can say simply Bard Parker handle. If they ask you, then you can say we have to fit in the blade over here. Okay, and my surgery undergrads, they gave me a blade and the BP handle and told me to fix it. Okay, so you should once do it in the wards or OT, wherever you're going. Just once try and do it before exams. Okay, Akbar lagiye, just practice it how to put it. Okay. And we don't have multiple instruments in here anymore. This is a heavy scissors. কি বল না কি বলবি চুপ করে বলছিস কি বলবি বল আমাকে তো বল যা বল নিজেরা কথা বলে যাবি আমার দরকার ঠিক so are key instruments important? Do you have, anyone has the book with you? So you can go through. So set wise, always try to read set wise. Okay, like when you are reading the instruments for the nose, always gather them. Okay, take it's, I mean, without instruments you cannot read instruments. It's extremely difficult. By seeing pictures it is, because you will not be able to identify it in the exam. The pictures, the book pictures are always different than the main instrument. It's way lot different. So, but for like for example, for nose, apart from this Thudichum speculum that we have seen, there is another thing called Killian speculum. It's very important. Killian speculum is always there in the specimens. Caesial speculum is called a Killian speculum they will give you in the exam only. Caesial they won't give. So that is for, what is it used for? So only the blades are longer. Okay, and it's like, how will I show you? So it has two handles. Even you press it, the blades open up. Okay, so we normally use it during septoplasty. Once we give the fierce incision, lift the perichondrium from one side, then incise the cartilage, go to the other side and take the cartilage, make the cartilage free. Then we put in the Killian speculum, open it up so that the flaps stay open and the cartilage stays within. And then we take the incision on the cartilage so that we don't damage the flaps. And it can also be used for deep examination of the nose, but to be honest, it's very painful. So we never use Killian speculum for examination purposes on a regular basis on day-to-day practice. So it's only for surgical purposes. Okay. So what are other important instruments? Anyway, no one has the book, huh? What about the PDF কিছু নেই? Yes. এখানে তো একটা বই রয়েছে, দেখে নিচ্ছি একবার দাঁড়া আছে কিনা। হ্যাঁ, everything এর মধ্যে আছে, কি আছে? So Wolf's eye lamp, like I said, you need to study because we don't have the Wolf's lamp over here. Then again, important for Wolf's lamp is the distance. Wolf's lamp is important key. How far it needs to be placed, what should be the distance between you and the patient and you and the Wolf's lamp. Size of the head mirror. Okay. The concavity. Okay, these things are important, so you just keep a note on that. Yeah, then comes the Thudichum speculum. We already showed you. The otoscope is not an instrument for undergrads. They won't give you otoscope, never. Okay, so this is a very important instrument, the Boyle Davis mouth gag for tonsil surgery. It's given to alternate students. Okay. So there are two parts of the instrument. Have you seen the instrument any time in the past? If anyone seen the instrument? Actually, the instrument. So it has two parts. Okay. So one is like a D, is the mouth gag, and there is one tongue depressor, which is attached to it. The tongue depressor is like this. It rolls in. Okay, so we roll the tongue depressor in fully, put the instrument. So the patient is in Rose's position. Tonsillectomy you have read, no? The patient, the neck is extended and we put the shoulder rolls, the neck is extended, and then we put the tooth guard so that we don't damage the teeth and the lips, and then we insert the Boyle Davis mouth gag inside. So like I said, it has two parts. Remember D for D. So the tongue depressor, it is the Boyle's part, and the retractor is the Davis part. Okay, sometimes they ask you which one is Boyle, which one is Davis. So remember the tongue depressor part. And retractor ta hocche Davis. So Boyle, D for D, you remember. Okay, that's how it's remembered. It's used for tonsillectomy. So there are the tongue blades come in multiple size. We don't call it tongue depressor. We call it tongue blades. Okay. So tongue blades come in multiple sizes. That is to retract the tongue and visualize the tonsils for surgery. Retractor tongue. Retractor one is the mouth gag. Only mouth gag. Don't call it retractor, mouth gag. And then after we put that boiled Davis mouth gag, and we retracted the tongue downwards, then what happens is the patient's head, it goes like this again. No? So we'll have to keep it like this. So what we use for it? We use something called a Draffin's bipod. So it's a metal rod which has like rings on one end. So there are 4 rings on each side. Okay. So we see this is this. If you see the picture, you'll be able to understand this one. Please see. So, like I said, so this is the B, the Boyle's part, the tongue depressor, and this thing is the Davis part, the D part. Okay. So we put it. Now we have pulled the tongue downwards. We have opened the mouth. The tongue is being pulled downwards. Eto obhi to thik ache, no problem. Then, and this is a catch, so self-retaining. So when we pull it, it gets retained in that place only. It doesn't come back. Okay. It has a catch, cut, and goes like that, and it gets fixed. So এরপরে কি হয়? And blue part is a Davis part. So and that lower down. So this is, so when we are using it on the patient, it's like this ulta. Patient তো শুয়ে আছে. So this is the thing, and the tongue we have depressed and taken up. সামনের দিকে we have নিয়ে নিয়েছি। এবার এই যে জিনিসটা রয়েছে, this is for the use of this Draffin's bipod. So we put these 2 holes, এরকম দুটো হোল পাশাপাশি ঢুকিয়ে মাঝখান দিয়ে এটাকে দিয়ে দিই, and then we position the bipod so that it gives, so this boiled Davis mouth guard hangs from it. বুঝতে পারছি, চেষ্টা কিন্তু ইনস্ট্রুমেন্ট সব বোঝানো extremely difficult. So this is how the Draffin's bipod look. Okay, so holes on both sides, put it and then put it in position. And this is the Magron's plate. ওখানে এগুলো না দেখালে সম্ভব না বোঝা। Important instruments হচ্ছে, আচ্ছা let's go with some basics. This, what is the difference between, how can you differentiate between a straight artery forceps and a needle holder?
Artery forceps এ ক্যাচ হবে?
ক্যাচ হবে না?
ক্যাচ তো হবে।
কি টিপ? এরকম পরীক্ষার সময় তুমি এরকম বললে হবে। Serrations, what is the difference in serrations?
Article horizontal.
But see, what is the idea? That's why, see, don't gulp, try to understand why it is made like that. Don't gulp.
Vertical একটা থাকবে।
Needle holder the serrations are crisscross, and artery forceps the serrations are only horizontal. Why is it crisscross? Have you seen artery forceps? ধর এটা একটা artery forceps. So there are serrations. এবার যে একটা নিডল আমি এর মধ্যে নিই and we catch it. Okay, যেহেতু একটা সেরেশনের মধ্যে নিডলটা পড়েছে, it will move like this. বুঝতে পেরেছিস? এখানে নিডল থাকলে দেখাতাম তোকে, খুব সুন্দর ভয়, একটা লাগিয়ে তুই ইজিলি ঘোরাতে পারবি নিডলটাকে, because it's only horizontal serration. But if it's a crisscross serration, so when you hold it, it will not move. For needle holder, we need the needle to be fixed. Okay, and then again the upper part of the needle is much smaller compared to the posterior part. It's much wider, so we can access close to what we are doing. So for artery forceps, we are trying to hold the structure, whether it's a vessel or a soft tissue, whatever, we are trying to hold it. So we need to visualize what we are doing. Okay, so those blades, the prongs can be longer, doesn't matter, because only the tip is working. Okay, but for a needle holder, we need to negotiate the needle. It's not about just holding. So we need proper control of the tip. So it has to be close to the structure we are performing upon. It can be soft tissue, it can be skin, it can be whatever. It needs to be close. So the prongs are much smaller compared to this, but catch দুটোতেই থাকে। ঠিক আছে, আচ্ছা আর কি কি ইন্টারেস্টিং জিনিস আচ্ছা নাকের মধ্যে কি আছে আচ্ছা অ্যাশেস ফসেস ওয়ালসন ফসেস তোরা জানি না তোরা দেখতে পাবি কিনা আই ডোন্ট নো প্রবাবলি নট হিয়ার that is a very important instrument. It's a Freer's elevator. Have you seen it? Freer's elevator কিন্তু থাকে পরীক্ষায় স্প্যাচুলার মতো দেখতে কিন্তু স্প্যাচুলার মতো কাজ নয় and there is one more thing is the difference between Tilly's forceps and Hartmann's forceps. Tilly's forceps and Hartmann's forceps. These are very important question. এগুলো লিখে রাখ এগুলো কিন্তু পড়বি হ্যাঁ Tilly forceps and Hartmann forceps the difference টা কি Tilly has a Hartmann forceps has a screw joint Tilly forceps has a box joint first and second is দুটোই nasal forceps but Hartmann it is Tilly forceps is much more traumatic than Hartmann forceps. Hartmann's screw joint Tilly forceps এর box joint দেখলেই বুঝতে পারবি না এখানে লেখাও আছে box joint screw joint and the end is grooved for Hartmann's. Freer's elevator is very important. কোন covers? There are multiple types of covers forceps actually. Smaller box থাকে covers usually box থাকে covers. Ashes forceps, Walson's forceps. এগুলো হচ্ছে for no it is used for nasal bone reduction or for rhinoplasty হ্যাঁ for lifting up ভাঙা যায় we normally do it when we do a rhinoplasty okay বল না শুনতে পাচ্ছেন জোরে বল nasal bone when we are reducing the nasal fracture when we are operating on the nasal bone this is so Ash and Walson forceps are for the external framework of the nose not for anything inside okay so it's used in rhinoplasty that is to structurally correct the nose or used for nasal trauma with fracture of the nasal bone where we can reduce the fragmented or the damaged part of the nasal bone. It's eustachian catheter Tilly harpoon अच्छा mastoid retractors are very important very important what is a mastoid retractor what are the types of mastoid retractors so one is a Mollison's retractor one is a Jensen's retractor okay so they have not given it right they have not actually giving it right so Mollison's retractor is both are self-retaining retractors in Mollison retractor we can open it and there is this thing this self-retaining thing that clicks to the point that we open up and the Jensen's retractor the image is actually wrong it has a screw kind of thing that we can open up and fix it where it needs to be fixed okay Farabeau's periosteal elevator very important Farabeau's elevator they ask so they will give you both the Farabeau's elevator and the Freer's elevator Farabeau আমরা বলি Farabeau's elevator this pronunciation is like that but the spelling is Farabeau B-E-U-F we say Farabeau's elevator okay so Farabeau's is typically used for periosteal elevation and Freer's elevator is for perichondrial elevation understand the difference Enteral speculum myringotum drill bar well forceps metallic syringe Laryngoscope Laryngoscope I think wow the tracheostomy you have read no tracheostomy will someone tell me the steps of tracheostomy फटाफट क्लास नहीं किया था ये छुट्टी पे था देख मैं हिंदी बहुत खराब है, वो जेंडर पे कुछ प्रॉब्लम आ जाता है, डोंट माइंड ना। কে করেছিস ক্লাস? তুই করেছিস? ট্র্যাকিওস্টমি ক্লাস করিস নি? তো বল আমি ট্র্যাকিওস্টমি স্টেপস গুলো বল। Tell us the steps of tracheostomy. নাম কি? বল স্টেপস গুলো বল। ভুলে গেলে কি করে চলবে? তাহলে পুরো লাভটা কি? তুই বলতে হবে। কতটা জানিস বল না, we will discuss it. Let's discuss something interesting. আস্তে আস্তে না, জোরে জোরে আমি যাতে শুনতে পাই। আরে তাহলেই তো ভুলটা বেরোবে, তাহলে তো শিখবি। Then only you'll learn না। If you say something wrong, then only you'll learn. First is, whenever you are discussing about a surgery, the first and the foremost thing is indication of the surgery. What is the indication of tracheostomy? The most common question asked from tracheostomy is, what is the indication of tracheostomy? Tracheostomy আমরা কেন করি? Why do we do a tracheostomy? Upper airway obstruction. One. If there is obstruction in the level of the lungs or the bronchus, will you do a tracheostomy? No. So upper airway obstruction. So there are two kinds of indication. One is an absolute indication, one is a relative indication. So nowadays, don't quote it in the exam, I'm just telling you, nowadays it is said that the only absolute indication for a tracheostomy is prolonged intubation. It is not even upper airway obstruction, because for upper airway obstruction, they recommend cricothyrotomy in place of tracheostomy. But don't quote this, always say the indication of tracheostomy, first indication is upper airway obstruction. So upper airway means
from the nose to the
say if there is an obstruction in the nose, we can intubate the patient through mouth. Why would you do a tracheostomy? So it's from the pharynx. Any obstruction from the level of the pharynx to the trachea, to the upper part of the trachea. So this is the area where if there is an obstruction, we can do a tracheostomy. Okay. So first, second and the most important indication, prolonged intubation. So patient having a CVA or something like that, or maybe a metabolic disorder or something, intubated in the ward, we typically get a call on the 6th or 7th day. This patient is probably going for a prolonged intubation, tracheostomies. Why? Why do we tracheostomize a patient? Intubate করা আছে laryngoscopy, aspirate, no, patient is intubated with a cuff tube. Why would the patient aspirate? That you can also do with that endotracheal tube. Think about it. Patient is intubated for a long time, and we and the consultant, the respective consultant in that department tells me, do a tracheostomy in this patient because we are planning for a prolonged intubation. We will need to be ventilated for a long time. Okay. Then we go ahead and do a tracheostomy. See, the problem with prolonged intubation is post-intubation stenosis. So if you keep the cuff inflated at high pressure for a very long time, the patient will have a stenosis later on. Many cases we have seen, many cases. At least I have seen 20, 30, 40 cases. And the patient also can have a tracheomalacia later on. Prolonged intubation is one of the very important indications of tracheostomy. Hello? Class নিচ্ছি রে, then so these are the two main indications, okay, and then we have acute infections like epiglottitis or whatever, any cause of upper respiratory obstruction, upper airway obstruction, okay. And another thing is laryngeal airway toileting, the tracheal toileting, when we need to, like someone was saying, for infections or secretions and all, we can aspirate easily. And another important indication is weaning from ventilation. See, ধর একজন patient in intubated, ventilated আছে. But you are planning to take the patient out of ventilation. Okay, so you have to make sure the patient is breathing enough and adequately. Then only you can extubate the patient, right? To take the tube out. So you give a trial. তুই টিউবটা বার করে দেখলি পেশেন্ট ব্রিথ করতে পারছে কিনা, পারলো না, ধর, then what you have to do? Again paralyze the patient, again put the endotracheal tube in. But when you are having a tracheostomy tube, you can simply disconnect the ventilator and let the patient breathe if you can breathe. If you cannot, you can put it in, because the tube is not going through the mouth or the nose. The patient is way more comfortable with a tracheostomy tube. You can walk around, do whatever you want. With an endotracheal tube, you cannot go like that. So it's easier to wean a patient of ventilation with a tracheostomy tube. So that is also a very important indication of tracheostomy. Okay. Steps, position, position, barking dog position. Neck extension with shoulder blades, and neck extension with head flexion. ঠিক আছে, shoulder blades. Actually not nose position, but see the idea, the difference between nose position and any extension. So when we are doing operating on the neck, our idea is why we are keeping the patient in that position to bring the larynx outside and the trachea outside, make it superficial as much as possible, so that we don't have to go deep. ঠিক আছে না, flex নেকে কোনোদিন tracheostomy করে দেখবি. If ever you have to do it in future, it is very difficult. We go deep, we can't find the trachea, we go deep. It's extreme. So sometimes patients come with stridor. Even with minor extension, they will have severe stridor and saturation will start falling. Okay, একটু extend করবে, saturation starts dropping. So we'll have to do a tracheostomy in a flex neck. It is very difficult, believe me, it's very difficult. So the idea of extension of the neck is to bring the trachea superficial. Okay, then we go ahead with the procedure. So what are the steps? So dressing, dripping, these things you all know. This is nothing. So always say antiseptic dressing from the level of the mandible to the mid chest. Okay, including the axilla. Always. Okay. Then incision. There are both the incisions can be given. I normally prefer horizontal incision because it's cosmetically better. So it is midway between the cricoid cartilage and the suprasternal notch. Okay, so that is the level of the incision. Short neck patients sometimes you will find. So recently we have tracheostomy. I'm telling you, it's an experience. It was a cardiac patient with some congenital abnormalities. He had a congenital aortic stenosis and all those stuff, but not very young. He was 16-17 years old. Planned severe aortic stenosis, planned for surgery. They tried to intubate, could not intubate because the patient had the trachea was carved because of scoliosis and all those things. So they called me for a tracheostomy. I went there. I wanted to do a fiber optic intubation first so that the patient is safe, and then we can take, because I also don't know the structure, but how the trachea is like. So once I open it, say open the trachea, and then I find that it is blocked. We cannot go further inside. The trachea is deviated. How will I put the tube like that? You understand what I'm saying? Suppose the trachea is like this. I open up at one place, and then I cannot put the tube in because it is not going, because the trachea is curved. That will be a problem. So I wanted to visualize with a fiber optic laryngoscopy. I went through a ventilating laryngoscope by this fiber optic scope. After a certain point of time, I could see nothing. I couldn't even understand where we should go. While the patient, the saturation was gradually dropping, we had to open up. The saturation was 50-55 at that point of time. So we didn't have much time. So we opened up, and believe me, the cricoid was not even 0.5 centimeter above the suprasternal notch. So I told the relatives from before that if I do a tracheostomy, I'll have to cut the cricoid because the part of the trachea in the neck is very less, and the patient will not tolerate a sternotomy. There's already saturation is dropping. You cannot afford to do a sternotomy, right? So you have to cut the cricoid. So what is the problem? Why did I explain that to the patient relatives? Because there may be tracheal collapse. So cricoid is a full ring. If you damage the full ring, the trachea may collapse. Patient may not regain his voice ever in his life. He may be permanently tracheostomized. Okay. So we went ahead to cut the cricoid. Luckily that you went in, not much of obstruction at that level. The patient was finally saved. He died later because of the cardiac surgery comorbidities, because he was very sick otherwise. But whatever, the point is, that was a failed intubation. So that is another indication of tracheostomy. Okay. So midway between the cricoid and the suprasternal notch, we are taking the incision. So once we incise the skin, then we get the. So it can be a horizontal incision, it can be a vertical incision, both. Both can be there. There's, we personally nowadays we prefer to take it in the skin crease. So that doesn't. If I know, see, for a cancer surgery, patient is having this bigger patch in the neck or something, reconstructive surgeries, we don't care much because anyways the cosmesis is bad. But if you are doing it for a prolonged intubation, so the patient may be weaned off from ventilation in a few days and may have a normal life after that. So you have to be particular about the cosmesis. It is important. So we prefer to take it in the skin creases. Then we retract the skin and we get the subcutaneous fat and the subcutaneous tissue. So we cut those tissues and then we reach the strap muscles. Strap muscles. There are two layers of strap muscles. What are the layers? What is this muscle? Sternohyoid. Okay, the first layer will be the sternohyoid. This is the outermost layer. So we split it. We don't cut the muscles. We split the muscle. Okay, keeping in mind always, and by palpating, we repeatedly palpate and to see. I was telling them like right now. তোরা ছিল না তোকে বলছিলাম যে বাচ্চাদের খুব difficult হয়. For kids doing a tracheostomy sometimes emergency tracheostomy is extremely difficult because the trachea is soft. You won't be able to palpate. You will confuse this with the carotid. This happened. People have put incision on the carotid. Okay, so for adults it's much easier because cricoid is the trachea is pretty hard. So you can definitely feel the trachea, keep it in the midline and then dissect on it. So we dissect the strap muscles layer by layer and gradually retract it, and then once we retract all the strap muscles, we will reach the, where is the trachea? There is nothing in between. What level are you doing the tracheostomy? Before that, you have the isthmus of thyroid. Okay. Don't forget that. Okay. It's very bothering. Sometimes it bleeds if you don't take care of it properly. It makes the feel very bad. We identify the isthmus of thyroid and we use something called a tracheal hook or a thyroid isthmus retractor. It looks like a double hook kind of thing. You put it over below the isthmus, we can retract it, or some people try to divide the isthmus. Nowadays it's not recommended. Earlier they used to do it. Nowadays we just retract the thyroid up and then we reach the pretracheal fascia. It is very important that you cut the pretracheal fascia before cutting open the trachea. So we use this dissecting forceps or natural dissecting forceps to lift the pretracheal fascia and remove it. Because if we don't do it, the patient will end up in a surgical emphysema. Post surgery, there will be air trapping in the neck. Okay, so that's why we need to remove then we identify the tracheal rings. Okay, so it may be a high tracheostomy, a mid tracheostomy, or a low tracheostomy. I think you have already read those things. When do we do a high tracheostomy? When we do a low tracheostomy? Suppose the high tracheostomy, you're going the trachea, right? So why not? So suppose there is a laryngeal disease and you're expecting it to go beyond the subglottis. Whatever, it can be malignant disease or granulomatosis disease, you're expecting it to go beyond the subglottis into the trachea. So you always prefer to go to a low tracheostomy so that we don't end up going through the disease. Okay. High tracheostomy is usually preferred in stride or in CLRN's patient where we expect the disease to be higher because later on the patient may need a laryngectomy. And at that time the tracheostomy will come within the margins. Okay. This is probably too much, na? বেশি হয়ে যাচ্ছে বলছে হ্যাঁ ঠিক আছে আচ্ছা ইনস্ট্রুমেন্ট গুলো you make sure we get all the instruments the next time. Okay, someone has to take care. Talk with the management if possible. Make us talk with the management. I will talk with Dr. Mujumdar or Mujumdar sir. You need the full set of instruments before. So exam is 1 year away. I totally understand, but then again, you need to at least 2-3 times you need to see. Otherwise, you'll forget. See, for an MBBS examination, I don't know how it is conducted these days. I mean, how difficult it is. The thing is, even 5 marks matters a lot. It's important. I have seen people passing at the exact pass marks many times. Okay, so it's very common also. This is not your higher secondary examination that you will score 90%, 92, 95%. In our days, 90% was a big deal. Now I think it's more.